Okay, hello everyone, welcome back. We are now on to our latest iteration in our TCCC series, our March algorithm, our intro into TCCC. We are at the end. We are finally on to head injury. This is the second H of March, and so let's get started, okay? We are in March 2025. We're dating them now so people know when they're done, and that way they know if we're out of date or not. Okay. If you can tell, I'm at work. I'm at a place where it's pretty chill, so I can do some 24-hour shifts, and so that's why it's quiet. Um, these were 20-minute videos, okay? That was the time frame. We had to do part one and part two to limit them to 20 minutes, but I'll just say this. Damn the time. Time is a construct. It's made up. It's a flat disk. Whatever you want to say about time, I'm over the time cap, okay? We're basically just going to deliver these to you in a manner which I think gives you the best amount of information that you need to make the decisions that are out there in the world that are challenging you. This is complicated. This is really difficult. People's lives are on the lines. I'm not going to limit it to 20 minutes. The entire reason why we're doing this whole training curriculum is because I think that current curriculums prepare people inadequately for the combat and traumatic experiences that they're going to face in real life. And so, where those curriculums fail, hopefully we will pick up some of those pieces. One of them is their time constraints to train you. I don't have that. I'm literally in a room. Often I'm in my backyard. I'm not getting paid for them. I can just do them for free whenever. You can listen to them whenever, so there is no time constraint. So it seems silly to make a time constraint on these videos. If they're going too slow for you, listen to them at 1.5 speed, listen to them at 2x speed, listen to them in the car ride, listen to them when you're on the elliptical, listen to them when you're on the rowing machine, whatever you got to do. And so I just want to give these lectures to the best of my ability, and the time constraint just limits that. This is a cool picture, cool website, Warm Fuzzy. You have all the watches, we have all the time. Supposedly an Afghan saying. No, no, that's really real, but there we go. All right, we've reached the end. Not quite. All right. The memes are for me. I build them into the lecture, but to keep me entertained while I'm building these. But basically, we haven't reached the end. Okay, this is the end of March. This is the end of our common framework, so that we're all speaking the same language when we discuss tactical combat casualty care. We discuss resuscitation of the critically ill. We do damage control resuscitation or whatever. We are now speaking the same language because we have learned a baseline framework together. This is not the end. I mean, if anything, Winston Churchill probably said it best. It is not the end. It is not even the beginning of the end, but perhaps it is the end of the beginning. So we are 6 lectures in, 7 if you count the intro lecture, and this really, basically is just the beginning of your journey into becoming an expert. Expertness does not start when your initial training is completed. You cannot complete your 6-8 whiskey training, your 4N training, your initial residency training as a physician, and then call yourself an expert. That's just not reality. That is just the end of the beginning. And so hopefully, I feel privileged to be at the end of your beginning, but let's get into it and learn more stuff every single day that we're taking care of other people. All right, here's what I'm going to talk about. Same thing as always. I have no financial disclosures. If you know somebody at Cat Tourniquet North American Rescue that wants to sponsor me, send them my way, dude. I would love that. I've added one in here recently. I do not speak for the DoD or the JTS. I am not a member of the Joint Trauma System. I do not write CPGs. I'm just like a dude out here in the wild living my life. This is all my opinion. It's based on my interpretation of other people's opinions and other people's data, plus my own experiences. I'm an emergency medicine physician. I was active duty in the Air Force, and now I'm in the Guard, and so my opinion is not based on nothing, but there's lots of people who have done more than me, who, maybe you should listen to them. It's up to you. Okay, here's what we're going to talk about. We're going to define the problem about TBI. We're going to discuss pathophysiology of CNS injury. I think this is a vast or often under-discussed topic when it comes to medic training specifically. We will go over the TCCC guidelines. I give you the guidelines as they are. I do not edit them. I put them verbatim in the lectures, so I don't want you to think that I'm changing them. Then we will talk line by line the critiques of some of these, and then some tips that I may or may not have. Big caveat here, this is not an all-encompassing lecture on traumatic brain injury. This is not an all-encompassing lecture on brain trauma. This is basically this discussion on head injury with the framework of TCCC guidelines, okay? In tactical field care, essentially. There's a much more in-depth lecture inbound one day, but not for this one. This is essentially the basics. Okay, how do we die in trauma? Newsflash, everybody dies. Kind of depressing, but the reality of it is everybody dies, and so how we die and why we die dictates what we're going to do about it because we can't treat everybody's dying the same. In trauma, we've talked about this ad nauseum, massive hemorrhage, airway obstruction, tension physiology. Got it. We've talked about that 1,000 times. But the other one is massive CNS injury. Okay, this is the fourth often not talked about one when it comes to trauma. Maybe because it's like these other ones are preventable death, and massive CNS injury is literally not preventable. And so unless you just didn't get hurt, and so that's what we're going to talk about today. Does CPR fix any of these? That's just a side caveat question. The answer is no. It doesn't put blood back in your body by pushing on your chest hard and fast. It doesn't fix airway obstruction. It doesn't fix tension physiology, and it certainly doesn't make your brain less hurt. And so, should we be doing CPR in traumatic arrest? No, it's probably dumb. Okay, these are CNS injury facts straight from the Joint Trauma System clinical practice guidelines. Okay, there I pulled them right off this paper. 14% of casualties in the JTS data bank have had TBI. Okay, so that's a lot of people. In 10 years, from 2001 to 2011, TBI was the mechanism of pre-hospital death in almost 1/3 of people. So just absolutely massive number. Okay, are those preventable deaths? They do delineate in their data. If you had access to that data, you can take a deep dive. But it is a big problem. 2001, 2009, TBI was the mechanism of in-hospital deaths for almost half the people. Okay, so not only is it a massive injury pattern burden, okay, so massive numbers of people are being injured in this way, but they're also dying because of that. Okay, and so traumatic brain injury is just something we have to be good at. We cannot tell ourselves that we are good at combat trauma if we are not experts at traumatic brain injury. Okay. Speaking of the experts, there were over 5,600 neurosurgical procedures performed in theater between 2002 and 2016. So your neurosurgeons are out there saving lives, doing their thing with their huge, long 40-year residency and their big, gigantic time commitments if they're HPSP. But they're out there saving lives, doing neurosurgical procedures, doing things that literally no one else can do. I fancy myself as just a master of all things as an emergency physician, but the reality of it is I'm not cutting anyone's brain open, and so these people, these men and women who do the neurosurgery job are quite remarkable. Okay, this is one of your neurosurgeons. Just kidding. This is Cuba Gooding Jr. I guess he starred in a movie, Gifted Hands. That's a real neurosurgeon, Ben Carson. He was the Health and Human Services Secretary or HUD Secretary or something. But he was a neurosurgeon before that, and he did a lot of pediatric neurosurgery and did some conjoined twin separations. So I don't know. We should all be lucky that people like him exist to do the brain surgeries that I don't want to do. Bottom line, TBI is a big problem. High mortality, high incidence burden. So we all say TBI is bad, TBI is bad, TBI, traumatic brain injury, mild traumatic brain injury, severe traumatic brain injury. But why? What actually happens to you when you have a traumatic brain injury? Sometimes we go along to get along. We don't actually know okay, my brain has a boo-boo, but why is my brain have a boo-boo? I don't know. I'm just Forrest Gump out here, just living my life. I don't know why. So let's learn about it. Pathophys. Okay, I'm sorry. I keep moving my camera around, my face around. Primary injury. There are basically two things that happen in brain injury. Primary injury is the first one, obviously. It is direct neuronal damage due to the trauma at the time of the event. Okay, it's essentially irreversible. It is what happens to you when the trauma happens to you. Okay, these are good examples. All right, this is a transitorial GSW. This is what side is the entry, what side is the exit. It doesn't really matter, but there is most likely a gunshot wound to the skull, through the brain, massive amounts of bleeding, fragmentation. There are obvious skull fractures, large external hematoma. This is air, these black dots. This is pneumocephalus. Here. This is, clearly devastating, massive injury. Okay. There is nothing anyone can do, not even Ben Carson or Cuba Gooding Jr., about the neurons that are broken and killed when this round goes flying through that person's skull. There's not a single thing anybody can do about that. So the goal is to prevent these secondary injuries. This is probably some other high velocity impact. Person fell off a building. Person was hit in the head with a hockey puck shot out of a cannon. Like, who knows what happened to them? Whatever it was super bad. Massive depressed skull fracture. Probably like facial fractures in there as well. And so there's nothing anybody can do about the smushing that happened to their brain. The neurons that were damaged when the skull fracture fragment like pushed into the brain. Not anything anybody can do about that. That is primary injury directly caused by the physical forces of their brain trauma. Copy? Primary injury, irreversible, bad for you. Secondary injury, this is where we make our money. Refers to the neuronal damage due to the sequela, fancy word for consequence, fancy word for what happens later of the primary insult. For example, all of these things. Okay, this is a huge list. Edema, elevated ICP, loss of cerebral autoregulation. We'll talk about that later. Your pulse ox goes low, your CO2 goes high, you have a seizure, you have a fever, vasospasm of the arterial system in the brain, which then causes distal ischemia, stroke symptoms, and then the paroxysmal, meaning intermittent, sympathetic hyperactivity as a driver of fever, and autonomic instability. Autonomic instability, when you hear that, I think heart rate go up, heart rate go down, blood pressure go up, blood pressure go down, and we don't know why. Okay, it is dysregulated autonomic function because your brain controls all things, and so when your brain is dysregulated, the other things will become dysregulated. All right, who are these guys? I went on like a history deep dive on this lecture, so just stand by to learn some shit. Okay, so these guys are the granddaddies, the fathers of intracranial pressure. This on the left, Alexander Monroe, Scottish physician. His daddy was a physician as well. And then on the right, George Kelly, also Scottish physician. Strangely, these guys have a doctrine named after them. They were not alive at the same time, but they picked up on each other's work and worked as a team beyond the grave, I suppose. There was another guy in here, John Abercrombie, who should have probably gotten some credit, but he doesn't, so that's life. These guys have basically discovered what is the Monroe-Kelly doctrine. Okay, this is like early medicine. This is in the 16 and 1700s. Alexander Monroe was born in 1697, so he was doctoring in the 1700s, and George Kelly was born in 1770, so he was doctoring mostly in the 1800s. The doctrine says the volume of the skull is fixed, okay? No matter what happens, my skull does not get bigger. The stuff in there takes up a certain volume. The brain about 80, the blood volume about 10%, CSF about 10%, sure, whatever. Those numbers are kind of irrelevant, but there is a certain number of stuff in there. If you have any increase in the volume of one of those things, it must lead to a reduction in the volume of one of the other or both of the remaining things, because my skull cannot get bigger. If I sprain my knee and I tear my ACL, okay, maybe I have less ACL in there, not really, but if my knee swells up, it's fine. My knee can get huge, my knee can get way swollen. My skull cannot get any bigger, so if I start bleeding within my skull, it's going to push on things that I need, like my cerebrospinal fluid, like, I don't know, my brain. And eventually get to a point where you're pushing on something that just can't give anymore, and the brain starts to have brain injury from that, and vital functions that your brain does become impaired because it is being smushed by the other things that are in that fixed space. That is the Monroe-Kelly doctrine. It's, the big principal idea of intracranial trauma and bleeding. Okay, what is normal? What is not normal? So normal ICP, normal intracranial pressure, is about 5 to 15 millimeters of mercury, and not normal is more than that, 20 to 22 millimeters of mercury for, let's say, more than 10 minutes. If someone's coughing or bucking the vent or having a seizure, and those are short-lived phenomena, that's not really an indicator to change management. If they're having a seizure, probably is. But if they're bucking the vent or doing these other things, it's not necessarily an indication they need emergent brain surgery. It's that you need to maybe control the things that are causing those transient elevations in ICP. But if they have persistent ICP for longer periods of time, like greater than 10 minutes, that is probably a starting time to require intervention. Of note, these can only be measured with after an invasive procedure by a neurosurgeon where they can actually measure the ICP. Otherwise, you're just sort of guessing. Okay. This is a fancy graph. I don't do graphs. I'm not a visual learner, so just bear with me because, I had to read it and think about it for a really long time. This one's relatively simple. So this is about compliance, okay? What this is basically telling you is that as pressure goes up, something happens to the volume. Okay, as the volume goes a certain way, something happens to the pressure. So what we're talking about is the conservation of space within the skull. So as you can see, like with a certain amount of volume increases, because we're increasing along this x-axis, the pressure's only going up slightly. It's not going up that much. But then suddenly you get here, and now just like minimal volume increases, cause like logarithmic exponential increases in pressure. Okay, so like that's like I give and give and give and give and give, and I don't break until suddenly, like, okay, sorry, I'm going to break now. I can't go any further without massive increases in pressure. We went like most of the way down this curve with minimal pressure increase. Now we went just a little bit more, and now we have massive pressure increase. This is compliance. And so your brain can tolerate some increased pressure, but eventually it does get to a point where it's now pushing on things that are too important. An old brain actually can probably tolerate a little bit more pressure, probably has greater compliance, because you see old people that get short and they shrink when they're older. Their brain also does that. So there's more space in their skull actually for other stuff because their brain's a little bit smaller. But somebody who's 19, 20, 25, 30, I don't know, 35 maybe, their brain is just full within the skull, and so there's less compliance probably. And those are probably our patients if we're talking about combat trauma. Cerebral perfusion pressure. Okay, this is probably more important than ICP. This is the driving pressure for perfusion, meaning blood flow, through the brain. Okay. Cerebral perfusion is the MAP, the mean arterial pressure, minus the intracranial pressure. And again, you'll need an invasive monitoring device to measure this ICP. Normal is between 50 to 90. Over 60 is probably best. Okay. The MAP is another annoying math algorithm, but it's 1/3 the systolic blood pressure plus 2/3 the diastolic blood pressure. Okay, so this requires math, this requires less math. CPP is a subtraction of both of them. Okay, you want it to be over 60. That is the goal. Okay, let's go back to this. Let's keep talking about this. So CPP is probably the best marker of cerebral perfusion, as we sort of said. Normally, like across a wide range of blood pressures, when you're back squatting 225 and your blood pressure is 290, your brain is able to auto-regulate the vessels and close them or open them as needed to keep the CPP at a relatively stable state. It doesn't want to see huge pressures, doesn't want to see certainly low pressures. And so your brain is able to auto-regulate its blood flow. When your brain is hurting, when your brain has a brain boo-boo, it is less able to do that. And so auto-regulation is lost, and it may cause your brain to receive more or less blood flow when it maybe needs less or more, and so it doesn't have the ability to change its blood flow by itself. Let's talk about like an example. Okay, so you have a patient who's hypotensive, they're a polytrauma blast injury, let's say, they have like an amputation maybe, they have obvious head trauma, let's say, and they're hypotensive from hemorrhagic shock, okay? You're able to resuscitate them, and you get them to what's a MAP of 65. It says MAP of 65. MAP of 65 is not normal, okay? Like, I'm not walking around with a MAP of 65. You are not listening to this video with a MAP of 65. You're 65. Your MAP is much higher than that, okay? And so if you resuscitate this person, you think they have a MAP of 65, but let's say we're concerned about elevated ICP. If their ICP is 22, 65 minus 22 is 43, dude. This is terrible CBP. It's just low. And so that's why we'll talk about some of the blood pressure goals for people with traumatic brain injury. But that's the CPP when you're thinking about what are my goals and what numbers do I need to hit for people. If they have an EVD or some kind of monitoring device for their intracranial pressure, this is the number you're really trying to hit. Okay? All right. Ignore some of these words, but this is basically the spiral of death, what happens when you have a brain injury. So you have some type of initial injury. This is off the Internet Book of Critical Care website. Awesome website. Can be a little tricky for some people who are maybe earlier in their career, but really great website. But you get reduced perfusion of brain tissue, then you get cerebral vasodilation, which, because it's lost autoregulation, then the volume of the blood goes up in the brain, which causes ICP elevation, and this ICP sort of reduces, elevated pressure reduces blood flow, and then you get this like spiral where it just keeps happening, and then the brain basically gets to a point where it cannot cope anymore. It causes brain ischemia, and then critical functions start to fail. Okay, this is for a different plateau waves, but it's basically one of the things that happens in brain injury. Cool. Here's my bottom line. Try to put these in there when I think I'm rambling too much. There's nothing you can do about primary injury. Okay, move on. They were shot in the head. That sucks. They should have zigged when they should have zagged. It is what it is. You can't do anything about that. Move on from that. The goal is to prevent or reduce the occurrence of secondary injury. Okay, so I'm in my room. My light went off. There we go. Reduce the occurrence or impact of secondary injury. That's the goal of neurocritical care. Okay. We're going to go through the guidelines now. I gave the guidelines as they are written on the CPGs. I don't want to bias you. I don't want to change them. We will talk about them sort of in a line-by-line basis, and I will give you my critiques on them. The TBI head injury CPG is quite short, honestly. It's like really not that long. And so despite that, I have a lot to say about it. Okay. If you see this slide with the joint trauma system, great logo, awesome logo, you know you're going to get, this is meaning straight from the guidelines, okay? It starts with unable to follow commands with either evidence of head trauma or blunt blast mechanism, okay? That's what they start with, all right? What does that mean, okay? What is like, or evidence of head trauma? Well, if they have like a penetrating head injury, that's pretty easy, but what are other ways to tell if they have head injury? So AVP used a good one, alert, verbal, pain, unresponsive, like what is their mentation? They're talking to you, hey, I'm Jim Smith, I got shot in the head, or they're grunting, or they're like not doing anything. Okay, that's all bad. We're trying to be experts, right? We're not trying to be neophytes, we're not trying to be newbies. So like we should probably get on the GCS train, okay? GCS is a thing on your left here. GCS is a scoring system that goes from 3 to 15. It does not start at 0. It starts at 3 because no response, no response, and no response. Those are scored at 1 point, and the best score is a 15. So learn the GCS. It's just more nuanced. It provides you more data. It's easier to evaluate if someone's declining because it has just more points in it. So someone can be verbal, but are they verbal with like just confusion? Are they totally oriented? Are they just like making weird sounds? Those are all verbal, but they're very different when you talk about if someone is declining in nature. And so GCS, we should probably just get on board with that, okay? The other is mechanism. All right, so you need this stuff, the ABPU or GCS, plus the mechanism, okay? If someone has like meningitis, they also have a brain boo-boo, but it's not the trauma kind. They will also be altered. They will also be confused. They might even be having a seizure. They might be posturing. Like, who knows what will happen? But it's not from trauma. And so the mechanism is important. These things are interpreted in context. It's like someone hands you an EKG and says, what's wrong with this person? Dude, it depends. Like, lots of things matter. And so when it comes to brain injury, the mechanism is important. Did they, did they have a fever? Did they trip and fall over and that's why they came to you? Or were they like blown up and fell off a bridge? Okay, that's totally different things. All right. When it comes to next guideline, prevent hypoxemia, goals 90 to 95, above that. If basic airway maneuvers fail and the SpO2 over 90 is not obtainable or feasible, ensure that the hypoxemia is not due to tension pneumothorax or hemorrhage. Okay, so make sure that their airway and oxygenation problems are not due to something else. Okay, that's a big one. You should be going through the guidelines in order to prevent that from happening, but just in case. Consider definitive airway if unable to maintain oxygen over 90, SpO2 over 90%. Okay. Hypoxemia has direct effects on mortality. Okay, so like hypoxia needs to be prevented sort of at all costs. Hypoxia and hypotension are the real big ones. Prevent those at all costs. Okay, so there is a Journal of Trauma article that I found. I know people got sick of me posting the articles in there, and so I post less articles now if I can help it, less screenshots. There's only one, I think, in this lecture. But 1996 Journal of Trauma, we went retro on the memes and retro on the journals this time. They're all old journals. 3x increased mortality. Okay, so 3-time increased mortality with episodes of pre-hospital hypoxemia in patients with severe TBI. Okay, so single hypoxic reading was also associated with increased mortality. So hypoxia is a big deal. Okay, this was an interesting study because it was pre-hospital, and so like I'm looking at you medics, I'm looking at frontline PAs who may be out there with their units. I'm looking at real hard charger docs. I'm working at paramedics. I'm looking at you guys, okay, Navy corpsmen. So like you guys are out there in the field with your dudes, and so the pre-hospital hypoxemia prevention is a big one, okay? They say definitive airway. Are they talking about cricothyroidotomy? I don't know, probably. Depends who they're talking to, I guess. If they're talking to me and I'm not in pre-hospital, then we're not talking about cricothyroidotomy because we're probably just going to intubate them. If they're talking about, 68 whiskey or Air Force medic who's out there in the field, maybe you are talking about cricothyroidotomy. Okay, there are lots of tactical considerations there. There are lots of medication considerations there. There are lots of experience considerations there. Try MPAs, try OPAs. I know iGel's out. We talked about that. But if you have one, I don't know, maybe it's your time to prevent someone from getting chopped in the neck. But again, follow your guidelines, but they are just guidelines. But they leave the word definitive a little bit vague, which is kind of interesting because in the airway section, they do not make it vague. All right, talked about this already. This is my second time filming this because the first time I filmed it, my mic broke. So I might be jumping the gun on some of the slides. All right, back to the guidelines. Prevent hypotension. Maintain BP 100 to 110. Give them whole blood. Give them plasma, preferentially if the patient is in hemorrhagic shock. Otherwise, you can give 1 to 2 liter bolus of crystalloid if there's no evidence of hemorrhage or hemorrhagic shock. Okay, TCCC says 100 to 110. Okay, I don't know. Brain Trauma Foundation recommends 110. We already said that we don't want a MAP of 65. We want higher pressures probably, and so this is a little bit higher than your regular TC3 blood pressure goals, which and so I don't know why there's a discrepancy in this Brain Trauma Foundation and TCCC and some other neurosurgery guidelines that I looked at, but that's just something to know about. That's why we're doing this thing. We're not training you to be a highly skilled technician. We are training you to be a thinking, living, breathing healthcare provider. And so just know that there's nuance and there's difference in different guidelines, okay? Single BP reading was associated with, single BP reading below 90 systolic was associated with 2 times mortality, okay? That's a prospective trial done by the Traumatic Coma Data Bank, okay, showed that single reading, and then also there's one article in here that we'll talk about. This is the only one, I believe. November 2006, multi-center study, journal Trauma, with all these guys that talked about pre-hospital hypoxia, and it broke it down a little bit more than that. So there was 150 patients in this study, so not a lot, but you get what you can, okay? They studied them for secondary insults, and they see okay, well, what did their secondary insults do to their bodies? Okay, so 57%, so a little bit over a third, had secondary insults. The mortality for patients without secondary insults. Secondary insults are what we talked about before: hypoxia, hypotension, seizure, those other things. The mortality for the patients without the secondary insults was 20%, so 1 in 5. For the patients with hypoxic episodes, the mortality was 37%. That's wildly different and wildly high. And then strangely enough, the patients with hypotensive, the mortality was only 8%, and then patients with both hypoxia and hypotension, 24% was the mortality. So all higher than just secondary insults alone. So maybe we can just say that hypoxia is the worst, hypertension is bad, but maybe not as bad as hypoxia. But this probably isn't a large enough study to draw conclusions that can say hypoxia is worse than hypotension in all comers at every level of traumatic brain injury. That's just the data is not powered for that. But it's probably enough data to say hypotension is bad for you, hypoxia is also super bad for you. Prevent them if you can at all costs. Okay? Continue on the same guidelines. So blood for the blood clot as usual. That's the altar that we worship at. If they're bleeding blood, give them some blood, dude. Don't give them other stuff. That being said, there's a big caveat to normality coming right now. Okay, so normally I basically tell you there's nothing normal about normal saline. Normal saline is profoundly acidotic. It's hyperchloremic. It causes non-anion gap metabolic acidosis. It's just horrible for you. Okay, the pH of normal saline is 4.5. The pH in your body is closer to 7.3, 7.4. Whereas lactated ringers is much more balanced, has much more normal concentrations of sodium. The pH is much more normal. Ignore all that for now. If they're hypotensive, you can give crystalloids. The recommendation actually being normal saline for brain injury patients alone. If they just have brain injury, the recommendation would be normal saline. Okay, and the reason is it does have this elevated level of increased osmolarity due to elevated sodium within the solution compared to lactated ringers and brains like that. And we'll talk about that later, why brains like that. Back to the guidelines. Identify and treat herniation, declining neurologic status with asymmetric or fixed / dilated pupillar pupils or posturing, and then interventions for signs of impending herniation should only be employed for up to 20 minutes, and, big and there, if en route to surgical decompression. We're going to talk a lot about this one. I have a history journey I want to take you on first. Okay, before that, how do I identify herniation? Identifying herniation, I'm sorry, I left my CAT scan goggles at home, so I don't really know how to identify herniation, so how do I actually do that? Worsening ADPU is one. They're getting worse, and you think it's because they're head injury, okay? More nuanced and better, more better because you're a good doctor, nurse, PA, NP, medic, paramedic. Better would be worsening GCS. It's more nuanced. You'll detect their decline earlier if you're doing frequent reassessments. Here's some late findings of herniation. Cushing's reflex, okay, so they get bradycardic, they're hypertensive, they have irregular respirations. If you have someone who has like massive head injury from a huge trauma and their heart rate is like 70, that's probably abnormal, dude. Especially if it was 120 or 130 before, 110, and now their heart rate now it's 90, then it's 80, then it's 70, and they don't seem like they're getting better. They're probably not getting better. They're experiencing this Cushing reflex, which is basically loss of autoregulation on the brain. They get high blood pressures and they get irregular respirations. And then you get pupillary abnormalities. You get pupillary abnormalities basically because the nerves that control the pupil, they get stretched or pushed or smushed, and basically you get fixed or dilated or fixed and dilated pupils on one side, both sides. There's a lot of different herniation syndromes that cause different pupillary abnormalities. Okay, this guy. This is our history journey. One of them. The second one. So this guy is Dr. Harvey Williams Cushing, American, of course, neurosurgeon, boss, hero of the First World War. So Harvey Cushing's contributions to battlefield trauma really cannot be understated. I mean, he traveled from America to France during World War I and was the consultant for neurosurgery to the American Expeditionary Forces. He treated hundreds of intracranial injuries during the First World War and was someone who was an advocate of early aggressive surgical management of brain trauma at a time when penetrating and blast trauma to the brain was like, people said, well, it sucks to be you, just go ahead and die now. And nobody used to do anything because people we didn't have the skill to do neurosurgery. But Dr. Cushing saved many soldiers, frankly, because of his aggressive treatments. And he has a couple things in medicine named after him. But this is a great book if you want to learn about that and other really interesting things from World War I that brought about the birth of modern medicine. So The Great War and the Birth of Modern Medicine by Thomas Helling. Cannot recommend it enough. It's really fascinating. There's a lot of really fantastic things that happened that came out of really what was a hellish time. And so the First World War, the devastation, 40, 50, 60 million people dying. We don't understand that today. Had that not happened, medicine might look totally different. Unfortunately, great suffering does bring about great change in the world of medicine. And this was one of those times. And Harvey Cushing, when we're doing neurocritical care today, we're standing on his shoulders. So thank God he was there. Cool. Moving on. This is a picture of brain herniation syndromes. Don't memorize them. Basically, here's the bottom line. The blood pushes on something, your brain, and it moves and goes under and pushes on other parts of your brain in various different patterns due to bleeding or edema from the brain tissue itself. And in the pattern that it does it is indicative of the physical symptoms you'll find, whether you have a herniation, blown pupil on the right, blown pupil on the left, etc. Weakness, numbness, whatever, motor defects. So there's a lot of different herniation syndromes, but suffice it to say, this is what happens. Blood goes in your brain, pushes on something important, and then you get hurt from that. That's honestly probably as in-depth as you need to know it, unless you're a doctor or neurosurgeon. Okay. Interventions for signs of impending herniation should only be employed for up to 20 minutes, and if en route to surgical decompressions. I don't like this one. I think this is stupid. I can't hold it back. I don't like it. I know I'm not a neurosurgeon. I know these are written for non-neurosurgeons, but I just don't agree with this at all. Okay, and I have like several reasons. The biggest one being like, dude, you don't know who's gonna make it and who isn't gonna make it. I've been doing the shop for almost 10 years, and I don't know who's gonna make it and who's not gonna make it. And so, like, just do the things that you think you need to do to take care of the patient with our big caveats in mind, right? Tactical considerations, equipment considerations, humanitarian considerations, whatever. Like, if you got 50 casualties and you got a dude who's probably dying of a massive brain injury and you only got a backpack worth of stuff to treat all your casualties, I'm sorry, that person's probably going to be expected. Make smart triage choices, but you don't know that the medevac you called for and didn't get approved isn't going to get approved. You don't know that the weather's not going to clear. You don't know that the tactical consideration is not going to change. The tactical changes that made EVAC or move to higher level of care not possible, you don't know that those aren't going to change. So I think we should make smart choices and give our friends and allies like the best chance to survive. Like if you say, well, I don't know, we're a 25-minute helicopter flight away, so I'm just not going to save him. That's insane, dude. Like, these are just guidelines, okay? But you're the one who has to live with yourself at the end of the day, whether you did the best thing. Now, don't sacrifice somebody who's not savable by using your stuff and miss out on saving somebody who could, but make really smart choices, okay? I think this is a really tough one that I just, I don't always like grossly disagree, but this is one I disagree on. The other things I disagree on this is like, which is a problem I have sort of overall the TC3 guidelines, which is they're built often for a mature theater. And so like if you have a role 3 and you have big hospitals and you have air superiority and you have all sorts of stuff, you can write guidelines like this because you might be able to get a lot of people to a certain place within a certain amount of time. But if we're going to fight in the Arctic, if we're going to fight a near peer on their soil, like we're just not going to have air superiority and we're not going to have quick evac times, and the golden hour is a myth and a thing of the past, and you're going to have to sit on people for long periods of time, then like this guideline just doesn't apply to you. It doesn't apply if there's no neurosurgeon in theater. Neurosurgeons only go to mature theaters. Like there's no neurosurgeon in theater on the first day of the war probably. And if there is, there might only be one. So like neurosurgeon is a valuable asset. They're not everywhere. There's only so many of them. It takes 12 years or 15 years to make one. And so like these guidelines are built for mature theaters. And so I just think give your people the best stuff you can, the best effort you can, within reason, with all the considerations that you would give every casualty. Only God knows the future. You don't. And then there is a hyperventilation discussion later. I probably wouldn't do that. Even, that hyperventilation improvement in intracranial pressure is a transient benefit, so I probably would not do that. Okay, that's the only caveat I have to saying no. All right, give them some 3%, 250 milliliters of 3% or 5% or 30 mLs of 23.4% hypertonic saline, slow in all caps, IV push over 10 minutes followed by saline flush. You can repeat it in 20 minutes if no response with a max of 2 doses. Make sure that IVIO site does not extrav and discontinue it if it does. Okay. Why does this work? What is it about hot salts that work? Really salty salt water. It's a fancy word called osmolarity. It sort of just boils down to like the amount of stuff in the water, basically. That's probably like the level that you really need to understand it is. It is the difference between pink Kool-Aid and deep, dark, super dark red Kool-Aid. Okay? In the red Kool-Aid, there's more stuff per part of water than there is in the pink Kool-Aid. It's not quite how it works, but that's an easy way to understand how it works. Normal blood osmolarity is that, 280 to 295. What is it in hypertonic saline? It's 1,026 milliosms per liter, I believe is that unit. Weird unit. So that's a lot more. It's like 3 times more, maybe a little bit more than 3 times more. Okay, so it's much more hypertonic. And basically what it does is, because it is so concentrated, essentially the goal is to draw water out of edematous or swollen or injured brain cells and draw water back into the vasculature to shrink those cells on a macroscopic scale, if you shrink each microscopic cell in mass and then reduce the intracranial pressure overall, okay? That is the goal. This one, so 3% can go through a peripheral IV. You really should push it slow, but the 23.4% probably should go through central line or IO. It can be caustic to the veins. It can cause you to sclerose the vein. And this one really does cause hypotension, so it really should be pushed quite slow. The hypotension concerns are legitimate, okay? What about mannitol? I heard about this thing called mannitol. Mannitol is a real thing. Mannitol is another option that can be done for intracranial trauma, for elevated ICP treatment. It's not in the guidelines. There's lots of different reasons for that. Some people think hypertonic saline works better, but mannitol is a tried and true reduction in ICP agent. But the main reason it's probably not in the TCCC guidelines is because mannitol works by causing osmotic diuresis, so it basically causes you to suck water out of the brain, ideally how it works, and then you pee it out. So the problem with that is it reduces overall body water, and you need to replace that volume. And so if you're bleeding to death from trauma, and then you now have the person peeing like freaking crazy, they're just like losing more volume, and you don't really want to make someone who's at risk for severe hypotension and trauma more hypotensive by making them piss like freaking 40 gallons a day. Okay, not gonna be that much. And so what you would do is you would basically put a catheter in and monitor their urine output very accurately, and you would replace that with normal saline. That's complicated. That's like, I'm at a secure, safe place and I have time to do heavy nursing care stuff. That's not really like a field problem, and so that's why most likely mannitol is like not in the guidelines. Okay, elevate the head of the bed if they're not in shock, and tactically feasible, loosen the C-collar if present and keep the head facing forward. Okay, reasons for this, you might have to get a little creative when you're doing, if spinal precautions are in play to elevate the head of the bed. What some people do is they'll keep them on their litter, make sure you strap them in that litter, they'll slide right down like a little playground slide, but keep them in the litter, strap them in, and then like you put a backpack or a pelican cage or something under the head, and so you elevate it, but they still have spinal precautions. Retro journal, as discussed, Journal of Neurosurgery, February 1992. How much does elevating the head of bed reduce the ICP? This showed about 5.5 millimeters of mercury reduction in ICP from head of bed of elevation alone. So that's awesome. The problem was there was no change in the CPP due to suspected MAP decrease because of that. Your MAP got lower because you got harder to pump up there against gravity, and so this is easy, like low-hanging fruit. Does it have benefit? It probably does have a small benefit. There may be earlier journals, but I just like this 1992 one. Or sorry, later journals, but I just like this 1992 one. It probably has benefit. It's pretty simple to do. It's low-hanging fruit. Make sure you elevate the head of the bed. When it comes to the C-collar, evaluate if you even need a C-collar first off, and ensure that it's not too tight. So make sure they even need it. If they do need it, the goal is to prevent it from pushing on their venous system, because what happens is if you push on the jugular venous system and you're basically reducing drainage from the skull into the neck and chest, you're increasing the ICP by keeping that venous congestion in there. So you don't want that C-collar too tight. Okay, hyperventilate. Hyperventilate using continuous capnography if you have it. End-tidal CO2 32 to 38. Okay. I don't really know where this rec came from. This is kind of an interesting one. So most of the societies, including the Brain Trauma Guideline, Brain Trauma Foundation, recommend like normocapnia, normal CO2, 35 to 45, with continuous end-tidal capnography being measured. I suppose like if you're you can play the what if game, right? Which is like, well, what if I'm really close to neurosurgical definitive care and, they're having the Cushing reflex and they now have a blown pupil and they're getting worse and I've already given the sodium. There's a lot of what ifs that you can do. I don't know, man, like that's a game time decision, I suppose. That the effect of hyperventilating someone basically reduces, it causes vasoconstriction, and it can reduce the ICP. That is real, but the benefit is quite transient, meaning you can reduce their ICP just for a little bit of time. And so I guarantee you, like, the second they hit the OR, they're not getting surgery, right? It does take time. And so it would be hard for me not to bag maybe slightly more aggressively if I was really close to definitive care and they seem to be getting worse. But just know that, like, that benefit is transient. If you can't get them in immediately or there's any delay, you may be causing a secondary rebound elevation in ICP. And so it's just something to think about. I don't have like an exact answer for that. We made it. We have made it to the end. Okay. We've made it to the end, but like, this is far from the definitive TBI treatment algorithm, but this is what TCCC recommends for initial treatment. And it's, for the most part, I think it's pretty great. There's a lot of things we didn't talk about. We didn't talk about seizure prophylaxis. We didn't talk about what happens if they get a fever. We didn't talk about glucose. We didn't talk about, evac and altitude considerations. And so we didn't talk about any of that stuff, but I think most of it's great. The prolonged care of a critical neurosurgical patient is tedious. It's quite labor intensive, and it requires really excellent physical exam skills, especially in the expeditionary environment, as well as like decisive action early in the patient's course to prevent secondary injury. Okay, and so it requires a lot of confidence. It requires you to really know your stuff to get down to it, and so that's why this guideline really is so important. Here's the bottom line. TBI is a massive component of battlefield trauma. Okay, if we're not good at TBI, then we can't call ourselves good at battlefield trauma. You cannot do anything about the primary injury. The goal is to prevent secondary injury. The Monroe-Kelly doctrine rules your life. Thank you to those two Scottish physicians to figuring this stuff out for the rest of us. The skull is a fixed space. Things that go into the skull are pushing on things that are already in there, and that's going to cause problems. Your dying brain will make the physiologic parameters abnormal in your body. The goal is to try to bring things back to normal. When your brain's trying to kill you, it's difficult to make everything normal, but that's our job before we can get a patient to definitive surgical care. Advocate to move patients to higher level of care with neurosurgical capabilities. Your patient cannot advocate for themselves. You have to be their advocate and emphasize that the patient needs neurosurgery. Remember, you're not a neurosurgeon. If you were, you wouldn't be listening to my recs on neurosurgical care. And so you need to move them. They're depending on you to be their advocate and push for them to a higher level of care. Because again, we don't know who's going to make it. We don't know who's not going to make it. Trust your gut. Do your best. I added this one in here. Be a good teammate. That's so critical. And then, of course, always stay in the fight mentally. March is over. Okay, we're done with our March algorithm. But what's next? There's a lot of stuff next. Probably DCR, damage control resuscitation. That seems to be like the logical next step. That's like a good one that I like. That's a fun one. It sort of brings March all together into resuscitation place. We may also just talk about like how to run a trauma from people who for people who maybe have never run traumas or seen traumas run. We might talk about burnout, residue, moral injury. Those are interesting ones. It's about time for my yearly sort of personal burnout, and so maybe I'll get in on that with you guys and talk about that. Burn is coming, so thermal burn injury is coming. That lecture's inbound. I have one that I've given before. I'll have to tweak it a little bit, but burn will come. Whole blood eventually is coming. I got some whole blood bags that I'm going to do some training with my unit, and so that'll be good. Heat injury, snake bites, always a fun one. Love snake bites. Orthopedics, less fun but relevant. Those are all coming. Okay, those are in the future. Hit me up. Let me know what you want to see, what you don't want to see. Sore throats that can kill you, weird skin rashes, stuff like that. Let me know if you like it. Send me your requests. Thanks for coming. You're getting better every day. Part of getting better is being involved in this stuff. And so your patients need you. Your patients rely on you. And so just keep up the fight. These are my sources. If anyone wants to check them, there's probably more, but that's most of them. Thanks, and I'll see you guys next time.